if we apply our Lirads, we will end up with LR4 category. And even though, again, this lesion has two anterior features of malignancy, remember, we cannot go from 4 to 5. So this was reported as LR4 category. CT was done 2 weeks later, and now, if we apply our Lirads tables, we're going to end up with LR5 categories, 2 weeks apart. Why can we call this LR5 definite HCC, but not the MR 2 weeks ago? What happened here? And you can see that the arterial phase was obtained at very different timing on MR as compared to CT, and we were able to detect our AFI here, but not here. Another example, fairly large lesion, AFI, no washout, clearly lesion with anterior features of malignancy. If we apply our table, it's going to be LR4 category. We cannot go from 4 to 5. I will keep saying that. But CT done 3 weeks later, look, now we have AFI and washout. And if we apply our table now, it's LR5. So again, what's happening here? And what's happening here is that this was done as an outside study. So for whatever reason, the MR did not obtain delayed phase on MR, but on CT, and that is when we detected washout. So how we acquire things makes a lot of difference for some patients, for some lesions, and we want to optimize technique to really get an accurate answer. So Lirads has required phases, and these are phases that we need to have to assess major features. And then we have additional sequences which help us assess major features correctly. So we have to have an arterial phase, but arterial phase is relatively broad. We can have early arterial phase and late arterial phase. How do we recognize them? Arterial phase, again, as I spoke before, is necessary for detection of AFI. Early arterial phase we recognize by a pacification of our arteries, and that's it. There's no contrast in portal vein at all. Late arterial phase, we have a pacification of arteries. We have some contrast in portal veins, but importantly, we have no contrast in hepatic veins. Now, why do we care if it's early or late arterial phase? Here's early arterial phase, right? Again, only contrast in arteries, no contrast in portal vein. The same patient, late arterial phase, now we have a pacification, a little bit of both arteries and portal vein. And now you can see that the HCC that same patient, same study, you can see that AFI, which is not visible on early arterial phase, is obvious on late arterial phase. So generally, we want late arterial phase because early timing may miss arterial phase hyperenhancement. Now, portal venous and delayed phases we need for assessment of washout and capsule. Portal venous phase we recognize by a pacification of both portal veins and hepatic veins. Now, delayed phase is going to look very similar. We have both a pacification of portal and hepatic veins, but the contrast between the parenchyma and the venous structures is going to be less stark. Now, why do we need the delayed phase? So another example, we have a fairly large lesion, arterial phase hyperenhancement, no washout in portal venous phase, nice washout on delayed phase, which allow us to give LR5 category. If we didn't obtain delayed phase, we would end up with LR4 category, which of course changes management drastically. And it turns out that 1/4 to half of HCCs may show washout on delayed phase only, especially the small HCCs. They may not show washout until 2 to 3 minutes after contrast injection. Now, then you may be asking, well, why do we need portal venous phase and delayed phase? And the answer, maybe we don't actually need that, because 99% of HCC that do have washout on, if you just look at arterial portal vein and delayed phase, you will see it. So we could omit washout and result, for CT at least, with 55% dose reduction. Do we need contrast on CT? Well, possibly, depends on the situation. On CT, pre-contrast is not required for patients who are being used for diagnosis, right? Because really the pre-contrast in this context, it has very low additional value and has extra radiation. But in patients who had prior treatment, pre-contrast may be important. So here's a patient, is it viable or non-viable? How about here, viable or non-viable? We do have some density. So in the first person, you can see that this area of apparent enhancement on arterial phase is really hyperdensity that was seen pre-contrast. So we can say there's no enhancement. This is non-viable disease, as opposed to second patient, which has nothing on the pre, and these are true areas of enhancement. So if the patient had prior treatment, we have to have pre-contrast because there's very high prevalence of hyperdense material in the post-treatment cavity. And then we need to have pre-contrast to assess whether or not there's enhancement. How about pre-contrast on MRI? So here's an example of lesion, right? It's brighter than the background parenchyma. Is it arterial phase hyperenhancement? How about this one? If we look at the pre-contrast in first case, the lesion is actually pretty bright as well. And so is the second lesion. So are we looking at shine through of internal hyperintensity or actual enhancement? So if we look at the subtraction for the first patient, clearly there is arterial phase hyperenhancement. So we can confirm this brightness is really true hyperenhancement, as opposed to the second patient, where we have kind of a black hole on the subtraction, so there's no arterial phase hyperenhancement. Similar for viable versus non-viable, you can see a lot of T1 hyperintensity in the cavity, and we often will need subtraction images to confirm lack of enhancement. So in essence, pre-contrast T1 on MRI is a required feature. MRI has additional required sequences. These are in and out of phase images, which allow us to detect background steatosis and then fat sparing in mass, and then internal fat and mass, which are ancillary features of malignancy. We have to acquire T2 weighted sequences. We can detect mild to moderate T2 hyperintensity, which is our ancillary feature of malignancy. We can detect cysts and hemangiomas as marked T2 hyperintense signal, and of course other things, including assays and assessment of other organs. Transition and hepatobiliary phases are required if we're using Diagnostic MRI, and then we can assess various ancillary features on hepatobiliary phase. Hepatobiliary phase hyperintensity, ancillary feature of malignancy in general. We can look at targetoid hepatobiliary phase, which I talked before, which is our LRM feature. And then hepatobiliary phase isointensity is feature of benignity. It's usually helps us confirm little shunts. MR also has optional sequences. Believe it or not, DWI is optional but recommended because it improves detection of observation. So I'm going to pause here for like a second and just look at these images. We have T2, pre-arterial phase, delayed. Arterial phase is very early, but still. How many lesions do you see, right? So our eye, of course, immediately jumps to this treated lesion in Fore. Everything else looks pretty decent. But how about now? So diffusion, you can see that the entire left lobe is studded in intrahepatic metastasis, which now knowing that, you can kind of sort of see that the portal venous phase is very heterogeneous. So this really helps us assess the extent of disease. TWI allows us to assess for mild to moderate diffusion restriction, as you can see here. And then we have targetoid and marked diffusion restriction, which are targetoid LRM and non-targetoid LRM features, respectively, as you can see illustrated here. So DW really is helpful, but why is it optional? And the reason being is it's a finicky sequence. We have inconsistent image quality. It's very prone to artifacts and image degradation. And you really have to invest in optimizing the sequences. And we didn't want to penalize those areas where DWI was just not feasible to do. Here's an example. Patient did really great, and then you can see the DWI is completely non-diagnostic due to artifacts. Another optional sequence is hepatobiliary phase if we use a gatabinate. And the reason why it's optional is because it's only 5% where this contrast is uptaken by the liver, and it takes about 2 hours. So anywhere between 1 and 3 hour delay is required to see hepatobiliary phase. So in many places, gatabinate is just used as an extracellular contrast agent, and hepatobiliary phase acquisition is optional because it's impractical to do it on every patient. Okay, so what are some technical consideration for CT? So we want to have appropriate slice thickness, right? So we want the slice thickness to be no more than 5 millimeters. Ideally, it should be somewhere between 2 and 3 millimeters for all phases. To time the arterial phase, ideally it's bolus tracking, where the technologist places the ROI at L1 level, and they kind of track, they track the contrast in this region, and then they see where the peak is, and that's our peak enhancement. And then that's where you scan 15 to 30 seconds after this peak enhancement. You can also do fixed timing. If you have the rate of 3 to 5 millimeters, you can time the arterial phase 35 to 45 seconds. It's nice, not as precise, but if you don't have tracking, that's what you would do. And then for the portal venous phase and delayed phases, you would do 60 to 75 second delay after start of injection for portal venous phase, and then 3 to 5 minutes for delayed. For MRI, arterial phase timing ideally is done by bolus tracking, where the tech plate, depending on the scanner, this is where you're going to place the tracker, but the tech will monitor the kind of the contrast, and once it reaches the predetermined area, they will trigger the scan. And then for portal venous phase, 60 to 70 seconds after injection will be our portal venous phase. Delayed phase for extracellular agents, 2 to 5 minutes. Transitional phase, 2 to 5 minutes if we're using getaxetate. And with hepatobiliary phase, 20 minutes with getaxetate. Anywhere between 1 to 3 hours with gatabinate. For T1 weighted images, we want to use 3D acquisition, and we strongly recommend fat suppression. Here's an example of the same image with and without fat suppression. So Dixon acquisition, so it's literally the same image with and without fat suppression. So you can see how the hyper enhancing lesions are a little easier to see when you apply fat suppression as opposed to without fat suppression. More importantly than anything is that the pre and post contrast sequences have to be acquired with exactly the same parameters. Otherwise, you can't really use the subtractions. And really, you want to optimize the technique for all the sequences. So here's an example. Patient with cirrhosis, kind of heterogeneous appearance on T2. But you really can't pinpoint something. And then the same exact exam, but with much better technique, better signal to noise ratio. Now you can see a large tumor sitting, occupying most of the liver, and you can see this was just a scar in the liver. But you can see how much easier it is to see it when the technique is optimized. So to summarize, there are required phases. These are the phases that we need to assess major features. These are arterial, portal venous, and delayed phase on CT. On MR, we have to acquire the same arterial portal venous phase. We have to have in and out of phase and T2 weighted sequences. And then for getaxetate, we'll also add hepatobiliary phase. DW is optional but strongly encouraged. And it's very important to have correct timing of arterial phase. We really want late arterial phase for assessment of our cases. And really invest in optimizing image quality because it will make a lot of difference. With that, thank you.
Thank you so much. We're going to take a few questions, then we'll move on to Dr. Anteng, who will go into the lexicon. So I have a couple good questions I want to get to. One, you were just talking about diffusion. Do you Now, currently, Lirads does not have recommendations about diffusion, or does it, in terms of what B values ideally one should use? And is there any consideration of whether using any ADC or quantitative data from diffusion at this time with Lirads?
Excellent questions. So there's a manual that is available to everybody from ACR website, and it has an entire chapter on Lirads techniques. So all the details are there. But there are the current technique recommendations are to have B value of 500 or above. Now, this was a sort of a compromise because ideally you really want to have B 800 and higher. B 500 is really insufficient. However, because this was, again, these recommendations are 7 years now old, there were some scanners that just could not handle B800 at the time. So at this point, B500 is still acceptable, but really it should be B800 or higher. In terms of ADC quantification, it's an excellent question. There are a number of studies that looked at using quantitative data from ADC map and looking at detection of HCC, stratifying aggressiveness of HCC. And if you look at any particular study, those numbers are impressive. The problem is that the actual ADC values are very, very dependent on technique, the scanner, the patients, so many variables that the numbers that you get in one study are often not translatable to another study, to another setting, another scanner. So at this point, we do not use quantitative data from ADC map. And it's just visual assessment if you see diffusion or not.
We have so many good questions, so I'm going to try and get just two more, and then we're going to continue on to on. What do you use the transitional phase for? Is it how do we use that?
Another fabulous question. And there are some people who believe that transitional phase is unnecessary, really, really unnecessary, because really hepatobiliary phase is more important. Transitional phase is really not an additive. The reason why we acquire it is twofold. First of all, you're waiting for hepatobiliary phase anyways, and it's another 30-second acquisition. Patients already on a scanner. So it doesn't add anything. It doesn't add anything in terms of time. So it's easy to acquire. In some cases, hepatobiliary patient books out and doesn't get hepatobiliary phase. Now you have at least the backup transitional phase. In some cases, patient is dancing on the table and you have that one transitional phase is the only one that sort of kind of looks okay. So under ideal condition, when everything is perfect, you really don't need to have a transitional phase because it's really not additive. But it's there because, sometimes it's helpful, if something goes wrong, and really it's at no cost whatsoever in terms of time or effort. So.
Okay, and then there are two other questions I want to get to, two themes. And so just for everybody, I'm not answering questions in order. I apologize. It's partly just functionally, but also I think I'm trying to catch the questions that kind of work in this segment of the webinar, and we'll answer the rest of the questions later. So we'll try to get to all of those questions, but I'm just trying to sort of preserve certain themes that I see. So one, I'd like to ask you just in terms of technique and approach is the use also of subtraction. And when you use it and the issue of artifact subtraction, how you handle subtraction, how much do you rely upon it? If you're not sure that the enhancement, do you use ROIs? So there's several questions related to the incorporation of subtraction, how reliable is it? And then the second question, which I think is an interesting one, relates to let's do that one first, and then I'll ask you the other one.
Phenomenal question, and so I think we have enough data and expert consensus to say that in lesions which are hyperintense on pre-contrast, you really to confirm arterial phase hyperenhancement, you want to use subtraction. You also really often cannot assess viability without subtraction when you have a lot of T1 hyperintensity. All that being said, subtractions are tricky because really you want to make sure that the registration is correct, and in most places, the radiologist has no control, like you cannot manually realign the images. For example, we have a program where you can do that, right? So if you can do that, that becomes more reliable. You can actually readjust and say, okay, well, okay. If you don't have that, which is most true for most patients, for most centers, you have to be very careful. And you have to look at everywhere else and say, okay, well, it looks like the images are not registered correctly, and therefore, subtractions really may not be helpful. And the signal that I see is really misregistration. And if that's the case, you just can't do it. Otherwise are not very reliable on the MAR because again, when you put the ROI, that number is really subjective and will depend on various things and not translatable to between patients, between scanners. So it's tricky when things are hyper intense on T1. It's tricky. Now that's for arterial phase. For portal venous phase, there's a really nice study that showed that reliance on subtraction images to assess for portal venous phase is actually detrimental. So I would probably caution against using portal venous phase subtractions, period. So for arterial phase, do it with caution, and be cognizant about misregistration artifacts. For portal venous phase, it's probably not a good idea to use it. Although again, if you go into manual right now, it says you can.
And one question related to, well, a sort of sub-question related to the CT. We talked a lot about MRI. One, people are using, some people may have photon counting and dual energy CTs. Is there any data, or do we feel very comfortable now that there's enough data to say that virtual non-contrast will be sufficient in these patients to assess as a non-contrast phase? Do we need the non-contrast phase on CT? And then my other question related is, if we have some discrepancy between CT and MRI in terms of Lirad categorization, how do we mitigate? How do we debate that, and how do we go from there?
Okay, I'll take the easier one first. Yes. So which is if you have discrepancy of CT and MR, right? Again, a lot of it will depend on judgment. You have to first try to figure out why is there just a discrepancy. For example, I showed you the discrepancies between CT and MR, and there was a clear explanation why, right? The timing of arterial phase was wrong. One didn't acquire delayed, one did. So when that's the explanation, it's easy. You go with like the modality that had the best technique, the best performance. That's what you rely upon. Now that is not always the case. Sometimes you have a perfectly timed arterial phase, CT and MR, and they show different things, and it is explained by the fact that the modalities have different ability to demonstrate certain things, have different contrast resolution, different things like that. So let's say if you have an MR that shows arterial phase hyperenhancement, but CT does not, it's a well-performed MR, it's well-timed, and you believe that this is not an artifact, you would trust the MR. If MR, let's say if you use get oxidate MRI and then you didn't have washout in portal venous phase, right? So for that, then you would not be able to say there's washout, but then CT does show washout, then you would trust the CT. So there's a little bit of kind of finessing. You also have to make sure that CT and MR are fairly close to each other in terms of temporal. We don't have an exact guidance based on expert opinions, within a month or two, but it's a very tricky area of how to combine CT and MR features because of all these things. You have to be careful, but keep in mind that CT and MR are different modalities and may or may not demonstrate features in the same manner. And then the other question was photon counting and
so photon and there's discussions about spectral CT, photon counting CT. So the issues relate to one, the use of a virtual non-contrast. Do you even need the non-contrast? I guess is part of the question. And then two, you're going to see more on that photon count. You're going to lower your KV, and you're going to see a lot more arterial lesions. If it's going to increase conspicuity, does that help us make it more confusing? How do we apply Lirads in those situations? Do we do anything differently?
So there's no good data for photon count to CT on Lirads. A little bit of that. So I'm just going to focus on spectral or dual energy. There are some data, and from my personal experience, I actually like the low KV images because they do show arterial phase hyperenhancement washout easier, right? Now, if you go back and window the, the regular, 120 kV images, you'll still see the same thing, but the low kV images, it's just so much easier to see. It's like smack in your face. That being said, there is no data to say, well, let's say, like, is our performance improving? So unfortunately, there's no data on that. I think that there's not enough people using spectral CT to drive that kind of research. There are plenty of people who like spectral CTs, but they're not, the overlap people who are interested in HCC Lirads and spectral CT, that Venn diagram doesn't.
Yeah, so currently there's probably not people using spectral and et cetera right now to get the data, let alone to apply it to Lirads. So certainly we don't have all the answers on that, but again, we rely on Lirads. If you see more lesions and if they're transiently seen, you still have to look at that portal venous phase. So the arterial, so I just get to the question, and we're going to transition right after this. What do you think is more important, the arterial phase or the washout phase? The arterial phase or the portal venous phase?
You can't have one without another. No, you can't. Well, okay, arterial phase obviously is crucial because you have to have arterial phase hyperenhancement to categorize something as LR5. So that's a must. But if you only have arterial phase hyperenhancement, you still cannot say something is LR5. So you need arterial phase. Really, probably you need arterial phase and delayed phase, and you could probably skip portal venous phase. You don't have, like, I don't have data to show you that, except for that one study that shows you that you can. But so you probably could, but as of right now, the recommendations are arterial, portal venous phase, and delayed, and each one of them is very important. The only caveat is that, if you screw up the portal venous phase, you have delayed phase to catch you. Arterial phase is, you have one shot at this.
Great. So we'll have to move on. Sorry, go ahead.
Sorry. Yeah, I mean, later on we can discuss is that one thing is there that we don't have Primovist. So we don't have the better hepatobiliary. So we have which only excretes 5 to 10%. And so a lot of centers only use extracellular contrast and few use multi-hands, which is the one which has 5 to 10%. So maybe when we have the discussion, maybe some thoughts should be spent on that also, because one of the questions is which MRI contrast is ideal. So unfortunately, the costing of Primovist is such in India. I don't know why is that we are not able to afford it. So it's still not widely available. I think some centers have started using, but it's not widely used.
Well, so the conversation whether it's extracellular or hepatobiliary that's better is a very involved and can get very contentious, because some people strongly believe one way versus another, and according to Lirads, there's no preference, right? Lirads says you can use either one. Now that may possibly change in next release if we have enough data to show that hepatobiliary phase hypointensity is a major feature, but it won't be that you have to use it, right? It will be just the categories application may be slightly different. Regardless of what it will be in the future, as of right now, there's absolutely no issue with the fact that you don't have hepatobiliary phase. All you need really for application of and getting to Lirads category is arterial phase, portal venous phase, delayed phase. Extracellular contrast agent is perfectly fine. I'm going to take 1 second. Somebody commented on my knowledge of calculus. That's actually my son was hanging out in my office and he was bored, and that's him. I do not have this. I cannot take credit for knowledge of calculus. It's my 16-year-old son.
Great. So I just want to, I'm going to transition to Dr. Tang, who's going to speak to more about the lexicon and maybe answer some of these questions as well. We'll keep trying to answer the questions as rapidly as they're coming. They're excellent questions. I just want to also just remind people that, so currently Lirads, it's a lot, Lirads is evolving, right? So right now we currently are also, again, we want everyone to use it. So we are currently, it's really addresses mostly favoring the extracellular contrast agents, although we have the ancillary features to address people who are using the hepatobiliary type contrast. So we do have some caveats for that. Lirads will have to evolve if we move to more non-contrast abbreviated protocols, et cetera. So we understand that, and Lirads is sort of evolving. So your questions are awesome because we also will try to incorporate those questions as we as Lirads grows and evolves, just as our field is evolving.
Any questions?
No, it's really good.
So Victoria, if you can mute, we're going to go on to Tang. Thank you.
Hi, Liz, and hi, Sonal, for organizing